Hello, we're going to get started. Thank you everyone for coming. My name is Brian Coakley. I'm one of the pediatric surgeons at Seattle Children's Hospital. My co-moderator for this session is Dr. Natalie O'Neill, Assistant Professor of Surgery at Children's Hospital of the King's Daughters. We thank you everyone for your attendance. Just a quick reminder, these sessions are really, really quick. The speakers have 2 minutes. There's 1 minute for questions. So I would just ask if anyone wants to ask a question that you have, please get up and make your way to the microphone as they're speaking. Don't think that's rude. We just need you to do that to keep the session going on time. And we thank everybody for their attention. So I think we're going to start with Dr. Lynn, who's going to be speaking about penetration of evidence-based practices into pediatric appendectomy care from the Niemeyer's Children's Health.
Okay. Hello, everyone. Thank you for the opportunity to talk today. I have no disclosures. So there are many practices for evidence-based medicine for uncomplicated and complicated appendicitis. The aim of our study was to evaluate implementation of evidence-based practices of pediatric appendicitis. These were some practices we were interested in. We used NISQIP Pediatric from 2015 to 2022 in kids less than 18 years old. We used a Cochrane-Armitage test to demonstrate trends over time. So for preoperative imaging, evidence has encouraged us to use ultrasound and MRI and discouraged CT use to minimize radiation. You can see here that ultrasound and MRI trends have increased, but CT trends have also increased as well. For uncomplicated appendicitis, evidence has shown no oral antibiotics at discharge and same-day discharge are safe and effective practices. And this can be reflected by decreasing oral antibiotic use and increasing same-day discharge over time here. For antibiotics after complicated appendicitis, the use of PICC lines for parenteral antibiotics at discharge is no longer recommended, and this can be seen by decreasing trends of PICC line use and parenteral antibiotics here. In conjunction, increasing discharge with oral antibiotics can be seen. Again, evidence has encouraged ultrasound and MRI use and less so CT use to minimize radiation to detect abscesses. And we can see this with increasing ultrasound and MRI trends, but CT trends have remained unchanged. So in conclusion, pediatric surgeons are doing well at elements of antibiotic stewardship, limiting invasive procedures, and same-day discharge for uncomplicated appendicitis. However, further work is needed on imaging practices to limit the number of CTs obtained in the preoperative phase for diagnosis and in the postoperative phase for abscess detection. Thank you.
Until so no one else is getting up. It's interesting that you mentioned the postoperative, what they do for an abscess. So I think a lot of us know to go for an ultrasound, because if you're not going to see an ultrasound, it's probably not worth going after, right? But then I can't stop my radiologist from saying, I love that abscess you found. Now I need a CT scan to figure out how to put a needle in it.
Yeah.
How can we help reduce the CT rate for that?
Yeah, so
just to put it in under ultrasound.
We're actually currently working with our radiologists to encourage MRI use before CT. It has been a QI project, and by talking with them as stakeholders, we've been able to get the interventional radiologist on board with using MRI first. And obviously, if they ask for a CT, we will get a CT, but they are very much okay with MRI use, and it's worked out well, and they're still able to place drains without issues. So.
Great job. Thank you.
Yeah.
For our next talk, we will have proteomics-based analysis of Wilms tumor, patient-derived xenograft. It'll be presented by Dr. Daniel Gailey, who's a resident surgeon at the University of Tennessee Health Science Center.
Hey, good afternoon, everyone. Thanks for the opportunity to present. We have no disclosures. Preclinical study of targeted therapies for high-risk Wilms tumor is limited by the low availability of Wilms tumor cell lines and the difficulty of downstream analysis of patient-derived xenograft or PDX tissues once they've been dissociated into single cells. Sorry, clicker's freezing here. But this issue seems somewhat unique to Wilms tumor cells. Oh, sorry. Whereas other pediatric solid tumors are readily cultured in vitro. And we furthermore observed that these PDX models rely on subcutaneous passaging of intact tumor tissue, whereas single cells and 3D spheroids exhibit unreliable subcutaneous engraftment. So this curiosity has really led us to ask the question, what are the key mediators necessary for Wilms tumor PDX cell survival and tumorigenesis? Because answering this question would help to optimize our model development and identify therapeutic targets for exploitation. So we began this endeavor by an exploratory proteomic analysis of 6 different PDX models using 3 conditions of intact tumor tissue, single cells after tumor dissociation, and 3D spheroids for each PDX model. On principal component analysis of the top differentially expressed proteins across all of our samples, we noted that the samples clustered together by condition rather than by PDX models, suggesting that tissues, single cells, and spheroids are more similar across PDX models rather than different conditions being similar within PDX models. On differential expression analysis, we identified 2 dominant clusters, which you can see here on this heat map of differentially expressed proteins. And we saw in one cluster at the top there of proteins that were uniquely upregulated in spheroids, and a cluster at the bottom that were uniquely up in intact tissues. So enrichment analysis of these clusters identified cytoplasmic translation, receptor-mediated endocytosis, and hemostasis pathways to be implicated in cluster 1, and proteins involved in extracellular matrix organization, integrin cell surface interactions, and angiogenesis to be implicated in cluster 2. So lastly, downstream experiments that are ongoing include validation of these findings by Western blot and RNA-seq, further characterization of various in vitro cultures of these PDX tumors, and in vivo screening for engraftment phenotype. Thanks to my PI, Dr. Murphy at St. Jude, and all of our collaborators there as well. I'm happy to take any questions.
I think this is great work. Awesome job. Now, do you think that the spheroids and like the different proteomics that are being expressed is like related to actual how tumors spread throughout the body? Or do you think that this is something just related to your mouse model?
Yeah, that's a good question. I think that a lot of previous work has sort of, there was one paper published out of Germany earlier this year in 2025 that characterized spheroids and hydrogel-embedded organoids and adherent cells as exhibiting different of the various histologies of Wilms tumor, whereas spheroids predominantly have like a blastemal phenotype and gene expression pattern in their phenotype, but that's something that we are further looking into. We're doing some other pilot experiments of injecting the spheroids and seeing, well, do those tumors that might grow or may not grow out of injecting, do they recapitulate the parent histology and pattern of growth? Yeah.
Great work.
Yeah. Thanks.
All right, our next presentation is on transcriptomics with in silico cell mapping highlights, transcription factor AP2 aberrations in pediatric Crohn's bowel. It's going to be presented by Dr. E. Paul Lerner from the University of Alberta.
Hi, everyone. I'm really excited to get to talk to you today, so thanks very much for the opportunity. My name is Paul. I'm one of the General Surgery and Clinical Investigator Program residents from Edmonton, and I'm talking to you about this project today because Canada has one of the highest rates of pediatric Crohn's in the world, but our pathophysiology for Crohn's is not that well understood. So over the last 2 years in Edmonton, we've built a national surgical biobank in order to support research into this disease, and so I'm excited to share with you some preliminary results from this today, looking specifically at 2 genes that we've identified that have not previously been associated with IBD that look like they're upregulated in severe pediatric Crohn's inflammation. We have no financial disclosures. We did use random forest analysis, and these are our funders. So the goal for this project was to identify novel genes and pathways that are associated with severe fibrostenotic Crohn's disease. So to do that, we performed bulk RNA sequencing on resected bowel from 9 children, comparing each patient's inflamed tissue to the adjacent non-inflamed margins. This revealed 560 upregulated genes in inflamed tissue, which largely mapped to enterocytes using the Pediatric Human Gut Cell Atlas. So this is a single-cell transcriptomic atlas of pediatric Crohn's endoscopic biopsies. However, when we did pathway analysis of these genes, we identified a subset of 86 genes that were associated all with upregulated pathways, and these genes mostly did not map to enterocytes. Instead, they mapped to fibroblasts, glia, and lymphovascular epithelium. So that was really interesting. And notably, when we looked closer at the 10 top most upregulated pathways, 4 of them involve the same 2 genes, TFAP2A, which map to glia, and TFAP2C, which map to stromal 4 fibroblasts. So we then wanted to validate these findings in protein expression using immunohistochemistry. So what we found was that TFAP2C is it appears to be more upregulated in inflamed bowel, and there's more of it here in the inflamed mucosa, shown in the yellow. And then TFAP2A, shown in the red, co-localizes really nicely with the glia in the myenteric plexus, shown here in cyan. And so in summary, the enterocyte stress in Crohn's may be secondary to dysregulated pathways that appear to involve these 2 genes in glia and fibroblasts. Both of these are novel in IBD and are promising targets for future study. So thanks very much.
Great job. I was curious, have you gone to the next step at all and tried to actually manipulate the pathways in hopes of like treating the fibrostenotic disease or preventing it from ever occurring?
So we haven't done that yet because I really want to validate this in more patients before we go to try to model, because this is only 9. So now with our biobank, we have now 34 cases that we've collected in the last year and a half since we launched it. So we now have a larger patient population to test this on. So I think once we do that, then we can start to move towards models. There are some mouse models available from Jackson Lab for these 2 genes, but they're fatal pre-birth. So they're probably we would need to use a Crelox model to look at a knockout later rather than to do something just from the beginning. But validation first.
Great job.
Thanks.
Yeah, thank you.
All right. Our next talk is a novel virtual gut model, anticipated glucose absorption rate with changing small bowel anatomy. This is presented by Megan Rosenberg, general surgery resident at UMass.
All right, good afternoon. Thank you for the opportunity to present our work. We've got no disclosures. So our gut model has been developed with the intention of investigating novel surgical interventions for autologous intestinal reconstruction in short bowel syndrome. Exploring new surgical options for these patients is limited by several factors. Surgical innovation is expensive. It relies on animal models, which ties in with both cost and ethical concerns. We always have to keep in mind that our pediatric population is vulnerable, and any surgical innovation needs to be well backed by preliminary research to minimize risks. And finally, short bowel syndrome is relatively rare and heterogeneous, which does make it difficult to study. Following extensive literature review to gather as much precise anatomic data as we could, we began a mathematical derivation to describe bolus movement through an in-section model, with each segment representing 1 linear centimeter of bowel. We started out with the Darcy-Weisbach equation, which we used to allow us to model the pressure drop through a pipe, the intestine, with a friction coefficient to as closely simulate villi function as we could, with a hydraulic diameter deforming in response to peristalsis. Existing studies have already established a glucose absorption of about 80 millimoles per hour per 25 centimeters of intestine, assuming 140 millimole glucose bolus, and we did utilize that as our absorption rate. The result is the formula that you can see there on the right. Our primary modifiable components are diameter, length, and bolus volume. So using this existing anatomic data, we modeled small intestine for a full-term neonate, a toddler roughly 2 years old, and an adolescent. We ran the model for glucose absorption at a normal intestinal length and then dilated the intestine up to 2 times its normal diameter. We see the absorption drops at about 2.5 times the diameter in the adolescent, but much earlier in the younger reference models. We then reduced the bowel length to simulate short bowel syndrome and then repeated the dilation factor. Our glucose absorption started around 50% in all models and then dropped immediately without a period of preservation like in the full-length intestine models. Overall, this suggests to us the possibility that earlier autologous reconstruction may be beneficial in short bowel syndrome patients as they experience maladaptive dilation. We hope to incorporate other types of macronutrient absorption in the future and begin running mock surgeries on it. And I'm happy to take any questions.
Well, at the end of your talk, you addressed my main question was, are you going to tackle proteins or fat absorption next?
That's our hope. I don't have the resources to go out and find the absorption rate, so unfortunately it's stuff I have to use that already exists, and the most reliable ones have been investigated in glucose in the past, so I'm talking with a few folks to see if we can obtain that data to incorporate it into the model.
Very cool.
Thank you.
Next presentation is entitled Unbiased Plasma Proteomics and Principal Component Analysis Identifies Candidate Biomarkers to Distinguish Injury Severity and Type in Children. It's going to be presented by Dr. Matthew Parrish from the Mayo Clinic in Rochester, Minnesota.
Awesome. Thank you for this opportunity to share our work. My name is Matthew Parrish, and I'm a general surgery resident at Mayo, and we have no disclosures. We know that injury is the leading cause of morbidity and mortality in pediatric trauma, and personalized medicine would be a paradigm shift in the assessment and triage of pediatric trauma. Proteomics enables us to study circulating proteins, particularly the changes in them, especially after trauma, and it would allow us to identify candidate biomarkers that we could then use to assess and use for diagnosis and triage. So we hypothesized that proteomic analysis would be feasible in pediatric trauma and that protein markers would change in response to trauma. So to do this, we prospectively enrolled patients age 0 to 17 who sustained blunt trauma and presented as a level trauma activation to our facility from the latter half of 2023 to the early 2024. Blood that was collected during their routine clinical evaluation was spun to plasma, and utilizing Olink Explore HT proteomics, we were able to quantify thousands of proteins. We then made comparisons between injured patients as well as age and sex match uninjured controls. And a second blood sample was taken from the trauma patients if able to prior to discharge. So we were able to enroll 21 patients with a median age of 14 years old and a median injury severity score of 11. As you can see here, this is a volcano plot, and it was able to identify 795 altered proteins between injured patients and the uninjured controls. The red dots highlight the most significantly altered proteins. And now this graph here is a plot of specific expression of a protein in the control patients and to the trauma patients, as well as to the second blood draw when able to. And as you can see by the orange box, there's significant elevated expression in the trauma patient that then returned to baseline prior to discharge. This pattern was also seen for a variety of other proteins when it comes to injury, but also in injury-specific regions such as abdominal injury when we compared those to the controls as well as to other patients who had other injury patterns. So, in conclusion, we were able to identify candidate protein biomarkers in pediatric trauma. Further research is needed to validate these findings and develop individualized objective tools for the triage and assessment of patients who sustain trauma. And I'm sorry, I didn't quite hear the whole question. Thank you. Thank you for that question. I'm not 100% sure on that. I know we took an unbiased approach, so we just explored. I don't know exactly if we did, like you were asking, surface level or not, but I could definitely look into that, and we'll follow up with you.
Fantastic job.
Thank you.
Okay. For our next talk, we have the impact of hyperglycemia on skeletal myoblasts, implications for neural tube defects associated with maternal diabetes. This will be presented by Dr. Sungyoung Kim, who's a graduate student at the University of Nebraska Medical Center.
Hi, everyone. Thank you. I'm also a surgery resident from New York. I have no disclosures. So why I did this research? Well, I actually stumbled upon this topic of omphalocele and neural tube defects. My dissertation project is on the impact of maternal diabetes on congenital heart disease. Why is it important? It's important because when you look at history, many major breakthroughs in science really happened outside of one's field of research. It's also very clinically relevant, as you see in this human data. Pre-existing maternal diabetes leads to increased congenital heart defects, neural tube defects, as well as omphalocele. So the question is there a shared molecular pathway between neural tube and anterior abdominal wall development? To that end, we hypothesized that maternal hyperglycemia impacts neural tube development by upregulating retinoic acid pathway and interfering with skeletal myoblast maturation. We first generated a mouse model of maternal diabetes. We inject streptozotocin twice, 2 weeks apart. And by the time you inject the second time, 100% of our mice became diabetic. Our A1C levels were increased. Lipid panel showed increased free cholesterol level as well as triglyceride level. There was no difference in HDL or LDL. Our phenotype data showed in our diabetic cohort, there was 42% increase in omphalocele and neurotrophic defects. And strangely, all of these neurotrophic defects were associated with omphalocele. Excuse me. These are some representative images of our embryonic day 14.5 mouse embryos. You see anencephaly, encephalocele, and sacroagenesis. And the omphalocele was there 100% of the time. For our mechanistic studies, we first looked at neurocrest cells. We wanted to look at their migration. This is only in vitro, but we cultured these in hyperglycemia versus normal glycemia. There was no difference in migration. We looked at skeletal myoblasts, and there was actually 5-fold increase in proliferation in cells cultured in hyperglycemia. This was followed by gene expression studies. And contrary to our hypothesis that hyperglycemia increases retinoic acid signaling, we saw decreased expression of RXR alpha and RXR beta, which are the retinoic acid receptors. And this HOXB1 gene expression was significantly increased. These are sagittal sections of embryonic day 10.5 embryos, and you see the HOXB1 protein expression is really increased in the coelom where the primitive gut is developing. So in conclusion, hyperglycemia increases proliferation and decreases retinoic acid signaling in skeletal myoblasts. There's no effect on neurocrest cell migration, and it's possible that omphalocele and neurotrophic association may represent a more severe type of neurotrophic defects. Thank you.
Wow, that's an incredible amount of work that you packed in that little talk, and really great. So I guess my one question I have is, to your hypothesis, if you feel like we've kind of showed that it increases proliferation, it decreases retinoic acid signaling, what are your next steps to show that this actually reduces myoblast differentiation?
You would really have to look at the in vivo sections and stain for those differentiated markers like OX4, OX2, those markers, as well as the skeletal myoblasts markers. But I think our primary next step would be to really knock out HOXB1 in mouse models, conditional knockouts in neurocrest cells alone, and see if that results in omphalocele, because that would really prove or let us know that what the really association is in terms of the cellular level and in vivo models.
Yeah, great.
Our next presentation is entitled The Role of Pharmacogenomics and Opioid Prescribing for Infants with Surgical Congenital Heart Disease, a single-center pilot study, will be presented by Dr. Bark from Children's Hospital of Los Angeles by way of Virginia Commonwealth University.
Thank you for the opportunity to present our work. These are our disclosures. Pharmacogenomic variants are known to influence metabolism and response, and they have been, oh, I'm very sorry, but this is the old version of my talk, and I added another one. This is an old version of my talk.
You have a new version?
Mm-hmm. Oh, this is the only version? Okay, that's all right. We'll start from the top. I'll ad-lib. So these are our disclosures. So pharmacogenomic variants are known to influence drug metabolism and response, and they've been increasingly used in clinical practice, mostly for chemotherapy and antibiotic stewardship, but it is also known that they influence opioid response. Excuse me, sorry. So our aim was evaluate this relationship between pharmacogenomic variants and cumulative opioid exposure in infants undergoing surgery for CHD. We did a retrospective cohort study, and we included all infants less than 1 year with surgical CHD. We included 6 pharmacogenomic variants, and they're listed here. The reason that we decided to study opioids is that, and review their genetic profiles, that theoretically 2 infants that receive the same surgery have different opioid needs based off their genetic profiles. And it will be important to know, based off of their genetic profile, if we can target specific opioid stewardship efforts to those patients that are most in need. So overall, we identified 48 infants in our cohort, and about 71% of them underwent open surgery, and 83% of our patients were homozygous for at least one pharmacogenomic variant. And this bar graph highlights the variants with the largest observed differences in morphine exposure among our cohort. The blue bar graph shows a wild type, the wild type MMEs, the heterozygous are the orange, and the green represents the homozygous variants. And so you can see that there's a monotonic trend that was observed. However, it is statistically insignificant. Overall, we will use this data to sufficiently power a future study to see if these observations are actually statistically significant. Thank you for the opportunity to present, and I'll take any questions.
Really excellent job. I was curious, were you able to look into any other potential confounding factors that might have had an influence on the opioids that they were prescribed, like duration of the surgery, time in the ICU, any postoperative complications, any of those sort of like external factors?
No, absolutely. That's a great question. And I don't know if you, as you saw, but we only included 48 patients. And I think originally we started with a cohort of about 100 patients. And so to try and minimize confounding and keep the cohort as homogeneous as possible, we limited it to just patients with congenital heart disease, and then further limited it to patients that had open surgery for their congenital heart disease. But absolutely, there are confounding factors that we haven't identified or we haven't adjusted for, because we wanted to make sure we kept as many patients as we could to see some type of association. But for the future, for sure.
Great job.
Thank you.
All right, for our next one, we have disparities in outcomes after presentation for complicated appendicitis in pediatric patients. This is presented by Dr. Kristen Kaiser. She's a resident at Indiana University.
Thank you so much to APSA for the opportunity to present today. I have no relevant disclosures. It is well known to this audience that complicated appendicitis is a very complex problem with longer length of stays and increased morbidity. It has been well published that social determinants of health affect the timing of presentation for appendicitis as a whole. For example, Child Opportunity Index, which is a surrogate for social determinants of health, has shown that patients with appendicitis will present later or in a delayed fashion when they have lower Child Opportunity Index. While this pre-hospital phenomenon has been well established, little is known about the in-hospital course with varying child opportunity indices. For those unfamiliar with Child Opportunity Index, this is a neighborhood composite that reflects education, economic opportunities, and healthcare access. So we hypothesized that patients with complicated appendicitis and a low COI will have higher or greater inpatient healthcare utilization. To do this, we looked at the FIS database from 2017 to 2022, looking at ICD-10 codes for complicated appendicitis. We looked at the outcomes of length of stay, TPN use, and ICU admission, and performed a bivariate analysis and multivariable logistic regression. Our cohort consisted of 40,965 patients, with a majority having low COI or a low opportunity in their environment. As you can see, that not only that patients with low COI are presenting late, but they also have longer length of stay once they've presented for complicated appendicitis, where low and mid Child Opportunity Index had a longer length of stay. They also were more likely to have an ICU admission, but interestingly, TPN use was the same and had similar utilization across Child Opportunity Indices. In conclusion, after presentation for complicated appendicitis, low Child Opportunity Index is associated with longer length of stay and more ICU admissions. Social determinants of health are impacting both those pre-hospital and inpatient factors. In the future, we hope to collect more granular data to identify if these patients need to be flagged or do they need additional resources on presentation to help decrease that healthcare utilization once they've reached the hospital. I'd like to thank my co-authors, and I'd be happy to take any questions.
No questions for the appendicitis? All right, it's all good. I think that this is a really nice addition to this expanding literature of COI and all of the different, especially common health disparities. So I appreciate your work. If you have a question, your question's probably better than mine. Let's go for it.
So really interesting topic, very important. Did you think about using propensity score matching for your statistical analysis to try to adjust for some of the more common variables?
Would you propensity score match on child opportunity index? Is that what you're suggesting?
No, some of the other variables that you can also control for, so that you can
Yeah,
split.
but what are you splitting your cohort into? Is what I'm asking.
Great. So if you say like propensity score match,
Yes.
like, age and
You,
stuff.
you would propensity score match on everything, yes. But then what is your outcome of measure?
No, I agreed. Same thing, like split along COI, but first propensity score match.
Okay. I mean, we didn't
Yeah.
do that. Yeah, absolutely could. I think especially in phys and big database studies like this, because you're missing like the severity of the patient factor, propensity score match is like usually most useful for like injury severity scores and trauma. And so in my opinion, doing that on social variables, there's a couple of limitations to that. And I think I have not personally used it on social variables.
Because I think it may help you tease out some of these differences a little bit more clearly, especially some of those percentages that are really close. I think if you do the propensity score matching, you'll probably get a clearer result.
Okay, absolutely, can do.
Our next presentation is entitled Children Transferred from Non-NSQIP Pediatric Hospitals Require Higher Rates of Cross-Sectional Imaging to Diagnose Appendicitis. This will be presented by Dr. Kwong from Rush University Medical Center.
Hi, good afternoon. Our project is about comparing the rates of cross-sectional imaging to diagnose appendicitis in children in NSQIP and non-NSQIP hospitals. So we know that the ultrasound is the preferred initial study for diagnosis of acute appendicitis in children, but we've noticed a high rate of non-diagnostic ultrasounds among outside hospital transfers, resulting in additional cross-sectional imaging. In the study, we sought to quantify this on a national level. We used the ACS NSQIP P database and included any child who had an ultrasound as part of their initial workup. We compared NSQIP and non-NSQIP hospitals as a correlate for high and low pediatric volume centers. And we used a log regression model and adjusted for a few covariates. A total of about 80,000 children met criteria. About a quarter of them were first evaluated in a non-NSQIP hospital and 3/4 at a NSQIP hospital. Among children who got an initial ultrasound at a non-NSQIP hospital, about 25% received a CT before getting transferred, and 1% got an MRI. 22% had an ultrasound repeated after getting transferred, 5% got a CT, and 2% got an MRI. Among children who got an initial ultrasound at a NSQIP hospital, only 18% got a CT, and 3% got an MRI. We found that children who went to a non-NSQIP hospital were indeed more likely to require additional imaging when compared to those who went to a NSQIP hospital, approximately 50% versus 20%, with a p-value of less than 0.001 and an adjusted odds ratio of 4.46. Our data suggests that children who were initially evaluated for appendicitis with an ultrasound at a non-NSQIP hospital were over 4 times more likely to require additional imaging than if they had presented to a NSQIP hospital. We think that perhaps low volume centers may be less successful at identifying pediatric appendicitis, and that this highlights the need to improve identification of appendicitis on ultrasound across hospitals of all kinds. Thank you.
Well, I have a question about this. Sure. So I get a call every single time I'm on call. Like it's literally 100% from a hospital in the community, and it's a very nice doctor who will describe a kid who basically does not have appendicitis. But you can tell from the history, I would say, and the normal white count. But they'll say the ultrasound couldn't find the appendix. We don't have MRI here. Family's insistent we exclude the diagnosis or else they don't want to go home. I can either A, do a CT scan here, or I can send them to you. What should I tell them to do?
It's a very good question.
I've heard it a lot.
Yeah, and we certainly get that as well. I think that the whole goal of this I don't have a great answer for you, to be honest with you. But the whole goal of this is to highlight the operator dependency of ultrasound as an imaging modality. And we're hoping that this is the first step in developing a tool to eventually help hospitals and the ultrasound techs better identify appendicitis. So I'm sorry, I don't have a great answer.
There's always apps in 2026, Chicago. We have a question from the audience. though.
Yeah, great data. Mike Livingston from Hamilton, Ontario, Canada. In Canada, we're quite regionalized, so we get a lot of these outside calls as well. And, I do have a sympathetic lens towards our community hospitals because they're really just trying to come up with a disposition in a timely way that makes the patient and the parents happy. So, what are some of the strategies that you one is sure, get techs in the community better at doing ultrasound, but can you think of any other strategies that you've been, exploring that could facilitate that process? Because I think it is more about just diagnostic accuracy. Some of it is around communication and expectations with families. Thanks.
There may be a role for some community education as well, but I totally understand. In a community setting, ultimately they're reaching out to ask for help, and I think that there's quite a bit of room for improvement out in the community and us as academic centers as well.
Great job.
Thanks.
Okay, more appendicitis. Up next, we have preoperative factors influencing negative appendectomy. It's a retrospective analysis of clinical characteristics, imaging, admission pathways using a national database. It'll be presented by Dr. John M. Woodward, general surgery resident, University of Buffalo.
Good afternoon, everybody. Thank you for the opportunity to present. We have no disclosures. So a pathologically normal appendix after appendectomy for suspected acute appendicitis is otherwise known as a negative appendectomy, and it is a risk of surgical management of acute appendicitis. The aim of our study is to use national data to identify preoperative risk factors of a negative appendectomy to aid in clinical decision-making. We utilize the NSQIP pediatric database from 2016 to 2022 to identify patients less than 18 years of age undergoing appendectomy for suspected appendicitis. And then based off of the pathology that came back, whether it was acute appendicitis or it was a normal appendix on pathology. And then we performed a regression analysis to identify which preoperative characteristics influenced a normal appendix on pathology. So we identified over 125,000 patients with a 2.3% negative appendectomy rate. And for modifiable factors that we identified, no imaging compared to ultrasound gave a nearly 2 times increased odds of having a negative appendectomy. And then direct admission from home or the clinic, bypassing the emergency room, also increased your odds of having a negative appendectomy. So, as we just said, the modifiable factors that increase the risk of negative appendectomy include direct admission from home clinic and no imaging in comparison to ultrasound. And ultimately, understanding these variables may help identify patients who would benefit from additional workup to help decrease the risk of a negative appendectomy. Thank you so much. I'm happy to take questions.
All right. Well, I think, so what I take home from this study is actually if you almost would go outside of our normal algorithm, go to the ER, get an ultrasound, consult general surgery, you sort of have a higher risk of negative appendectomy rate. Is that correct?
Yeah, I think it's getting the potentially emergency room providers to look at the abdominal pain first, potentially a wider differential. And then certainly.
I mean, I know people who will really tout themselves and say, no, I saved them an ER visit. I saved them the imaging and took them right to the OR because I know it was appendicitis.
I think running a concurrent cost analysis on this would be quite appropriate, and unfortunately, I did not do that. Thank you so much.
Were you able to do that
No.
cost analysis? Not
No.
Your database? Okay.
No, unfortunately.
All right. Thank you so much.
Thank you.
And last but not least is our What's Brewing in Perforated Appendicitis. It's a 7-year single-center retrospective study to be presented by Dr. Corey Worth, the general surgery resident, postdoctoral research fellow at the University of Rochester Medical Center.
Thank you so much. I have no disclosures. So the overarching theme of my research has been developing a novel therapy to treating the contaminated abdomen in pediatric perforated appendicitis. And the contribution of individual microbes to postoperative organ space infections still remains unclear. So the objective was to examine the bacteriology and the antibiotic susceptibility of pediatric perforated appendicitis with a focus on those who develop a OSI post-API. And we hypothesized that antibiotic resistance confers an increased risk of developing an OSI postoperatively. So using our institutional NISQIP pediatric database, we performed a single-center retrospective cohort study where we identified all patients who underwent an appendectomy for perforated appendicitis from 2016 to 2023. All patients with confirmed complicated appendicitis were included, and we also reviewed the culture data from those who wound up getting a second procedure for a presumed OSI. Culture data were available for nearly 36% of the patients who underwent appendectomy for complicated appendicitis. And to no surprise, E. coli, strep anginosus, Bacteroides fragilis, and Pseudomonas were the most commonly identified on index cultures. Now, E. coli and strep anginosus had pretty high propensity for antibiotic resistance, whereas Pseudomonas and Bacteroides really had low rates of documented antibiotic resistance. Interestingly, the presence of strep anginosus or Pseudomonas species on index cultures did not significantly increase the odds of developing an OSI, whereas patients with Bacteroides fragilis or antibiotic-resistant E. coli strains did have an increased risk of developing a circular space infection, with both of their odds ratios being greater than 2. So taken together, this study showed that Bacteroides fragilis and antibiotic-resistant E. coli strains in pediatric complicated appendicitis are associated with presumed OSI, and strep anginosus and Pseudomonas species weren't necessarily conferring an increased risk of OSI based on our data. And most importantly, these results helped us focus our attention on the primary bacteria we needed to kill when developing the technology to treat the contaminated abdomen. Thank you very much. Happy to take any questions.
Hello, my name is Kayla Ramraj. I'm from Memphis. Could you comment on what your institutional practice is on postoperative antibiotics for patients who have perforated appendicitis, and at what point in time these abscesses were developing that you then cultured?
So for your first question, what the standard practice is right now for perforated appendicitis, correct? So oftentimes we're using a ceftriaxone metronidazole protocol, and then depending, it's kind of a empiric basis, we will kind of escalate to a Zosyn if need be, but we do try to go for the ceftriaxone metronidazole for 3 to 5 days. The second part of that question is oftentimes we're seeing these patients develop the OSIs, or at least symptoms of where we're suspecting that anywhere between 5 days to 7 days post-op. Obviously, there's some margin, standard error there. It could be between 3 to 10 days, but oftentimes it's 5 to 7 days post-op. But we included patients all the way up to 30 days in our data set. We captured everyone 30 days post-operatively.
Thank you so much.
Thank you so much.
Okay, we did it. We're all done. What a great group of quick shots we had, and thanks everyone for keeping it on track. So if you have any additional questions for these presenters, please find them later on. Next, we have a great set of breakout sessions and 2 different workshops. So there's special sessions for residents, but please take a look at your Whova app and choose which breakout or workshop session you would like to attend. Just a reminder, all breakout sessions will be recorded, so you can see sessions that you're going to miss or not able to attend here. Finally, after the breakouts and workshops, we'll gather back here at 5 p.m. We have refreshments, our annual favorite great cases session. All right.